welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of acute otitis media in children designed for general pediatricians. Acute otitis media is one of the most common bacterial infections in childhood and a leading reason for antibiotic prescriptions in pediatric practice. Throughout this lecture, we will work through 10 carefully designed clinical cases covering clinical presentation, otoscopic findings, pathophysiology, diagnostic workup, differential diagnosis, treatment decisions, antibiotic failure, complications, recurrent disease, and special considerations in neonates and young infants. By the end, you will have a structured framework to confidently diagnose and manage acute otitis media in everyday practice. Let us begin. Question 1. A 2-year-old boy is brought to the clinic with 2 days of fever at 38.9 degrees Celsius, ear pulling, and irritability. His mother reports he had an upper respiratory infection 1 week ago. On examination, the right tympanic membrane is bulging erythematous and has reduced mobility on pneumatic otoscopy. There is no discharge, and he has no known drug allergies. What is the most likely diagnosis? Option A, otitis media with effusion. Option B, acute otitis externa. Option C, acute otitis media. Option D, eustachian tube dysfunction. The correct answer is option C, acute otitis media. The diagnosis of acute otitis media requires 3 components: acute onset of symptoms, evidence of middle ear effusion shown by bulging tympanic membrane and reduced mobility on pneumatic otoscopy, and signs or symptoms of middle ear inflammation such as erythema, otalgia, or fever. This child has all 3. Bulging of the tympanic membrane is the single most predictive finding for acute otitis media. Otitis media with effusion involves middle ear fluid without acute inflammation, so there is no fever, no pain, and no bulging. Otitis externa involves the external ear canal and not the middle ear, typically presenting with tragal tenderness and canal swelling. Eustachian tube dysfunction causes a feeling of fullness and mild hearing loss, but lacks acute inflammation. Question 2. A 14-month-old girl presents with 3 days of fever at 39.2 degrees Celsius and fussiness. Her parents note she has been pulling at her left ear. On otoscopy, the left tympanic membrane appears yellow-orange, bulging, and opaque with loss of the light reflex. Pneumatic otoscopy shows markedly decreased mobility. Which otoscopic finding is most specific for diagnosing acute otitis media? Option A, erythema of the tympanic membrane. Option B, loss of the light reflex. Option C, bulging of the tympanic membrane. Option D, opacification of the tympanic membrane. The correct answer is option C, bulging of the tympanic membrane. Among all otoscopic findings, bulging carries the highest specificity and positive predictive value for acute otitis media. It reflects the accumulation of purulent fluid under pressure in the middle ear space. Erythema alone is non-specific because crying, fever, or even cerumen removal can cause redness of the tympanic membrane. Loss of the light reflex and opacification are supportive findings but are less specific than bulging. The American Academy of Pediatrics 2013 guidelines specifically emphasize bulging tympanic membrane as the primary diagnostic criterion. Remember the practical rule: if the tympanic membrane is bulging, think acute otitis media until proven otherwise. Question 3. A 3-year-old boy attends daycare and has had 4 episodes of acute otitis media in the past 12 months. His parents ask why he keeps getting ear infections. Which of the following best explains the primary pathophysiologic mechanism leading to acute otitis media in young children? Option A, immature cochlear hair cells allowing bacterial invasion. Option B, eustachian tube dysfunction leading to negative middle ear pressure and bacterial ascent from the nasopharynx. Option C, deficiency of immunoglobulin A in the external auditory canal. Option D, congenital abnormality of the tympanic membrane. The correct answer is option B, eustachian tube dysfunction leading to negative middle ear pressure and bacterial ascent from the nasopharynx. In young children, the eustachian tube is shorter, wider, and more horizontal than in adults, which facilitates bacterial ascent from the nasopharynx into the middle ear. The typical sequence begins with a viral upper respiratory infection that causes mucosal edema and eustachian tube obstruction. This leads to negative middle ear pressure, fluid accumulation, and secondary bacterial colonization. The 3 most common bacterial pathogens are Streptococcus pneumonia, Haemophilus influenzae, and Moraxella catarrhalis. Key risk factors include daycare attendance, age under 2 years, pacifier use, lack of breastfeeding, and exposure to tobacco smoke. Understanding this pathway also explains why most children outgrow recurrent ear infections as they grow and their eustachian tube becomes more vertical. Question 4. A 6-month-old infant presents with 2 days of fever at 38.7 degrees Celsius and irritability. The tympanic membrane is bulging and erythematous bilaterally. The parents ask if any tests are needed to confirm the diagnosis. Which of the following is the most appropriate next step in the diagnostic workup? Option A, tympanometry. Option B, audiometry. Option C, clinical diagnosis based on otoscopic findings, no further testing required. Option D, tympanocentesis for culture. The correct answer is option C, clinical diagnosis based on otoscopic findings, no further testing required. Acute otitis media is fundamentally a clinical diagnosis. Pneumatic otoscopy is the gold standard diagnostic tool, combining direct visualization of the tympanic membrane with assessment of its mobility. Tympanometry is a useful adjunct when otoscopy is inconclusive, but it is not required for straightforward cases. It also cannot detect inflammation, which limits its diagnostic value in acute disease. Tympanocentesis is an invasive procedure reserved for selected situations, including treatment failure, immunocompromised patients, neonates with acute otitis media, or toxic-appearing children. Audiometry plays no role in acute diagnosis and is reserved for chronic hearing loss evaluation. The practical message is clear. A confident otoscopic examination is all you need to make the diagnosis in most cases. Question 5. A 4-year-old girl presents for a routine visit. Her mother mentions she has been hard of hearing for 2 months, but has had no fever, ear pain, or recent illness. On examination, the tympanic membrane is retracted, amber-colored, and has visible air fluid levels. Pneumatic otoscopy shows reduced but present mobility. Which diagnosis best fits this presentation? Option A, acute otitis media. Option B, chronic suppurative otitis media. Option C, otitis media with effusion. Option D, cholesteatoma. The correct answer is option C, otitis media with effusion, also known as glue ear. This condition is defined by middle ear effusion without acute signs of inflammation, meaning no fever, no otalgia, and no bulging tympanic membrane. Key features include a retracted or neutral tympanic membrane, amber or yellow color, visible air fluid levels, reduced mobility, and conductive hearing loss. Hearing loss is often the only complaint and can affect speech and language development if persistent. Acute otitis media is excluded because there is no acute onset and no inflammatory signs. Chronic suppurative otitis media presents with persistent ear discharge through a perforated tympanic membrane. Cholesteatoma presents with painless otorrhea, keratin debris, and a retraction pocket or perforation. Management of otitis media with effusion is watchful waiting for up to 3 months, with audiology evaluation if persistent. Question 6. A 2.5-year-old boy presents with 1 day of right ear pain and fever at 38.5 degrees Celsius. Otoscopy confirms right acute otitis media with moderate bulging. He has no drug allergies, no recent antibiotics, and no severe symptoms. His parents prefer to avoid antibiotics if possible. Which management approach is most appropriate according to current guidelines? Option A, immediate amoxicillin 90 mg per kilogram per day for 10 days. Option B, watchful waiting, also called the observation option, with a safety net prescription. Option C, immediate azithromycin for 5 days. Option D, immediate amoxicillin clavulanate 90 mg per kilogram per day for 10 days. The correct answer is option B, watchful waiting with a safety net prescription. According to the American Academy of Pediatrics 2013 guidelines, the observation option is appropriate for children aged 2 years and older with non-severe unilateral acute otitis media, defined as mild otalgia for less than 48 hours and fever below 39 degrees Celsius. A safety net prescription means giving the parents a prescription to fill only if symptoms worsen or do not improve within 48 to 72 hours. When antibiotics are chosen, amoxicillin 90 mg per kilogram per day is first line. The duration is 10 days for children under 2 years and 5 to 7 days for children 2 years and older with mild to moderate disease. Azithromycin is not first line for acute otitis media because of high pneumococcal resistance. Amoxicillin clavulanate is reserved for treatment failure, recent amoxicillin use, or coexisting purulent conjunctivitis. Question 7. A 3-year-old boy was started on amoxicillin 90 mg per kilogram per day for acute otitis media 3 days ago. He returns with persistent fever at 38.8 degrees Celsius, worsening ear pain, and a still bulging tympanic membrane. He has no drug allergies. Which is the most appropriate next step? Option A, continue amoxicillin for 7 more days. Option B, switch to azithromycin for 5 days. Option C, switch to amoxicillin clavulanate 90 mg per kilogram per day amoxicillin component. Option D, refer immediately for tympanocentesis. The correct answer